OrthoTV. And today we have the pleasure of having Dr. Dhiren Ganjwala from Ahmedabad, who's going to take an interactive case discussion session with the DNB residents. So all of you should be ready to answer questions. Otherwise, the point of an interactive session gets lost. So I think without much ado, since we're already a little behind time, let's start. Over to you, Dhiren.
Yeah, thank you. Just a minute, I would just check because I'm not able to see that thing. So I will need to change my view. So, yeah.
So can all the people, Rajan, etc., you switch on your video so that you and your audio so that you can participate? And Rishu, wherever you are, he's gone into hiding, I think.
Yeah, so let's start the show. Is my presentation, that's the issue. Yeah. Yeah, you can see the presentation, right?
Yes, sir.
Yeah, thank you. So welcome to this very unique session. And in this, we are going to discuss interesting cases, but it's not in the form of lecture. What we are going to do is like there is a teaching method which is called a guided discovery method. And basically that is very important for developing the thinking ability of students. So I will be using this skill in this presentation. So suppose you want to be a master blaster like Virat Kohli, then by watching the betting on a video or going to the cricket ground and watching him is not really going to make you the good batsman. If you really want to be a good batsman, then you really need to carry out a practice and then only you will become a good batsman. So that is what the whole concept is about. This is going to be an interactive session. And in that, when you try to answer, whether your answer is right or wrong, that's not important. But when you try to answer, you will gain the understanding of the topic. So don't worry about the rightness of the answer. Just try to answer the question. So we are starting with a very statutory warning that smoking is injurious to health. And why I say like that, we are like a Sherlock Holmes. When patient comes to us, we don't know the diagnosis. And we really need to use our thinking skill and we need to make a diagnosis. So all of you are going to use the head which Sherlock Holmes was using. And by using that skill, finding out the minute point and then making or trying to answer is going to help you. So let me start with the first case. This is a case, a 14-year-old boy with a genu-valgum deformity. I will give you a brief background, how this patient presented to me. The initial orthopedic surgeon, which was very near to their residence, he said that there is something abnormal in the knee joint. So he asked for the MRI. The MRI report came and that shows that there is a posterior cruciate ligament which is deficient, and which could be because of the injury, and that could be the tear. Frankly, there was no history of injury. So orthopedic surgeon got confused that what needs to be done for a congenital absence of posterior cruciate ligament injury or ligament problem. So he referred to the arthroscopist. Arthroscopist was a very smart and experienced person. So what he did, he examined the patient clinically and he could not find any ligament instability in the patient. And so he said that this is basically a genu-valgum deformity and the pediatric orthopedic surgeon is the right person to tackle this. So then he referred that person to me. So the first question is, from this short narration about the case, what do we learn?
The clinical examination is foremost important for making any
Yes,
diagnosis.
that's the very important message I would like to say. Now, most of the time, we don't spend time in clinical examination and we try to look at the fancy investigation. And that basically sometimes may take us in a completely wrong direction. Now, think of this boy if he would have undergone a reconstruction for the posterior cruciate ligament injury, the primary problem would have remained like that. And something else would have been done and the patient would be miserable in that case. So now if we summarize, this is a 14-year-old boy, bilateral genu-valgum deformity. In addition to that, the two important thing, he has a uncontrolled seizures. Since childhood, he had uncontrolled seizures, and for that he is taking a number of medicines, anticonvulsant medicine, and at present he is on 4 anti-epileptic medicine. Still, occasionally, once a week, he gets seizures. In addition to that, there is a impaired cognition or the IQ. So now the question is, should we correct the deformity or not? With this background, a 14-year-old boy, bilateral genu-valgum, these are the two medical problems. Should we correct the deformity or not?
Sir, we should correct the deformity, but he is having 4 anti-epileptic medicine on,
Right,
and patient is occasionally having seizure, which is not controlled by medicine. So
right.
first we have to medically correct the patient. First, patient do not have the seizure on medicine. Then after that, we will correct the deformity, sir.
Okay, you are very right in thinking. And so I asked the neurologist who was looking after this boy since last 12 years. He told me that, Dr. Dhiren, this is what the best we can do. In spite of the latest anticonvulsant medicine, still the number or the frequency has gone down, but we are not able to control it fully. I discussed this point with the anesthetist. He said that fine, during anesthesia, we will be able to manage the seizures issue with the anti-epileptic medicine. And if required, we will give IV anti-epileptic medicine and we will be able to take care of that. So let's understand or let's accept that anesthetist says that we can go ahead with the surgery. But the important question is, should we correct the deformity or not? That's the important question. I want others to respond. Yeah,
No,
Emil.
sir.
Yeah, please.
No, sir. We will not correct deformity right now, sir.
Okay, then at
Because
what stage we should correct the deformity?
at least if the anti-seizure medicine is started right now, then we have to wait for 2 to 3 years.
Yeah, Emil, like this boy is on anti-epileptic medicine for 12 years. And
Yes.
with the various anti-epileptic medicine, combination of that, still the seizures is not fully under control. He had been to a higher center for the surgery for the brain to control the epilepsy, but they said that no, he's not the right candidate for that. So that option is also now ruled out. So whatever is the situation, we are now have to decide, should we go ahead or should we wait? And by waiting, what we are going to get, because the neurophysician said that this is the best, we have tried everything and we cannot offer anything more to this boy for the epilepsy part. So with
So,
that information, yeah,
the patient is 14 years old,
yeah.
so we most probably need osteotomy.
No, that is the next question. But the first question is, should we correct it or not? So basically, when you suggest osteotomy, you are saying that we should correct the deformity. So we are coming to
Yes.
the next question, that how will you manage? Whether you will go for a bracing, will you go for a growth modulation, or will you go for a osteotomy?
Sir, we will
We'll
look
go
for
for osteotomy, sir, but not any open type, close waist type osteotomy.
Okay, close wedge osteotomy. Okay. Anyone, Subbu, what is your opinion?
the first we look for an 14-year age, most probably he's having the growth arrest, and then we will, if there is possibility, because he's having seizure, or maybe the growth arrest will not be there. Matlab, there is some physical growth is possible. So
Okay,
we will look
right.
for X-ray. If there is a physical growth possible, we will go for growth modulation. And otherwise, if there is a growth arrest, then we will go for osteotomy, sir.
Okay, right. Yeah. Emil, you said that you will go for osteotomy. Why? Yeah, Emil. Yeah. Why do you suggest osteotomy?
The osteotomy, the main 2 years should be left. Also, sir, we can go for growth modulation with not through 8 plate, but through some other permanent type of growth modulation.
That's the
Pets,
next question. But
maybe pets, sir.
basically, when we are facing a situation which is 14 years. So first of all, let's understand that when it comes to the growth remaining, for a girl, we consider that the 14-year is the end of the growth, and we don't consider for the growth modulation. In the case of boy, we consider that 16 to 18 is an age where the growth stops. So 14 means at least chronological age, we have 2 years of growth remaining. So the important point is whether to go for a growth modulation or an osteotomy, we have to look at the factor. The one is, I just would like you to think on this point, like what are the factors which you would consider in deciding to go for a growth modulation or to go for osteotomy? It's not like one factor. There are multiple factors which you have to take into consideration. So what are the things which you will consider?
We will take the X-ray of elbow. We'll take
Perfect.
X-ray of pelvis.
Right.
We'll see.
Why you will take X-rays of elbow, X-rays of pelvis? Very good. So why you want to take X-rays?
We'll see the how much growth is remaining, sir.
Okay.
Get the chronological age.
Okay. So basically, we take the X-rays to decide the how much growth remaining. Very good. So that's the important point. The second important point is like we need to look at the how much is the amount of deformity, because if sometimes we say that the elbow X-ray says that the child has only 1.5 year of the growth remaining. If deformity is mild, we can definitely go for the growth modulation. But if deformity is more, then we cannot go for growth modulation. So these are the two important factors. And then the X-ray should be also there to find out the reason for the growth problem or this deformity. So already you have answered that you will take the X-rays of the elbow for deciding how much growth is remaining. So we usually take, when it comes to the end of the growth, the elbow AP and lateral X-ray is a good way to decide what is the age of a child. So now elbow X-ray showed that there is a more than 2 years of growth remaining. And so we decided to go for growth modulation. So the concept of growth modulation, I'm sure that you know all the concept of growth modulation, but just to make you clear, let's say that this is right side of the knee joint. There is a valgus deformity. The line which you, horizontal line which you see represents the growth plate. And when we apply an implant like this is a plate construct where it is also called a tension bend plate, and it's applied on a convex side. So this plate and a screw construct will stop the growth on a medial side. The lateral side will continue to grow like this, and gradually the deformity gets corrected. So this is what the concept of growth modulation. Good. So now the question is which implant you will use for growth modulation. Somebody answered that question in between, but yes, this is the stage where we have decided that 2 years of growth remaining and we are going for a growth modulation. What types of implant we can consider?
Yes, Sachin. सचिन काफी देर is not able to. You are not able to hear him. Subhanshu?
Sir, 8 plate, we can use 8 plate growth modulation, sir, on the medial side.
Okay, so you will go for the 8 plate. Anyone else would like to think of something else?
And we have to also check the deformity, whether it is in femur or in tibia.
Right. So the deformity is both in the femur and tibia.
Yes.
Other than 8 plate, what else is used for growth modulation?
Transphysial screws are also used, sir.
Okay, so transphysial screw. So some people they use transphysial screw and some people they use 8 plate. So when we say 8 plate, basically that's the name of company's name. The Orthofix plate is called the 8 plate. The concept is the tension band plate, which already I showed you in the animation. So one option is 8 plate. The other option is transphysial screw, which is called the PET screw method or the Matizio method. What else? Which other implant we can use?
Staples.
Staples we can use, right? Good. Staples, screws, transphysial screws, 8 plate. What else?
Old methods, sir, drilling the growth plate.
So that's the permanent epiphysiodesis. So should we use the permanent epiphysiodesis or we should use a temporary thing?
Temporary, sir.
Why?
Because we want to correct the deformity, not the fix the deformity at the current.
No, both the method, the permanent and the temporary epiphysiodesis are basically for correction of the deformity. The one is reversible, the other is not reversible. So when we say permanent, when we drill, it's a permanent thing. So what is the problem with permanent method? Why nowadays we don't use it and instead of that we use this temporary method?
Sir, after the deformity is corrected, if there is a more growth is present, so that opposite deformity will happen if we do the permanent.
Right. So that's very important. When we are doing a permanent epiphysiodesis, the timing is very important. If you are not doing it at the right time, if you do it early, then there will be a possibility of reverse deformity. If you do late, then there will be a chances of inadequate correction. So the advantage of this tension band plate or the transphysial screw, which are temporary, is that if the correction is achieved, then we can remove it, and then the longitudinal growth will again continue, and that is the advantage. So in that case, we should not worry about the timing of surgery. If you are doing it permanent method, means you are drilling the physis, then you have to be very particular about the timing. Good. So let me tell you, you mentioned about the standard implant. However, in India, always there is a cost constraint and we need to find out a easier option.
Sir,
So
one
in
more,
this,
sir.
yeah, please.
I want to add, sir. Yeah, one for tubular plate can be added.
Yes, so one tubular plate or reconstruction plate can be used. And in this case, what we did, we took a 6-hole plate and divided into two. So now we have a 2 implant reconstruction plate implant, which is having a 3-hole. And we use that implant, the reconstruction plate, for that. So that's basically very cost-effective thing. And we did it in this case. And this is a post-operative X-ray. And we expect that over a period of time, the lateral side will grow and that will correct the deformity. So yes, we always do it with good expectations, but sometimes our luck is not good, the patient's luck is not good, and we don't go in a desired direction. So on the 12th day, when patient came to me for removal of the stitches, there was a swelling at one of the sites. The child was operated at 4 sites, but at one site, at femur, we observed that there is a swelling. The pain was also present. The range of motion on that side was restricted. However, there was no sign of infection. So we removed the stitches, the healing has taken place well. But because of the swelling, I asked for the X-ray. And this is what the X-ray. On the right side, we can see that. What is the problem?
Backing out, sir.
Backing out.
Backing out.
Good. So now the question is, the question which family will ask, and we also need to answer, why did it happen? And the next important question, what should be the next line of action? So now the first question we are discussing is like, why did it happen?
Sir, screw are not in divergent maybe.
Okay, so the first possibility is that the screws are not divergent, but it's not necessary that all the time when you apply the tension bend plate, it has to be in a divergent method. But yes, you are saying that because they are parallel, the implant can come out, shift laterally. Yeah, that's the one argument we can always say. But that's
Osteopenia.
not osteopenia could be the another reason. Okay, good. What else? Or can we, some people can blame that it's because of the plate which we use, which is a Stepford plate, and that could be the reason. But fine, at this stage, we are not discussing it further. And now the next question is, already there is a problem, and we now need to offer a solution. So what is the solution?
Sir, revision of the same procedure, sir.
Revision of the same procedure. And as you said that now, instead of a parallel screw, we should try to go for a divergent screw. Is it something like that? You can always say that like there is a cortical screw also which has a very less purchase, and instead of that, if you use something else, then probably you may have a better purchase, and that may prevent the complication.
Locking screw, sir.
Locking screw. Okay, so you are suggesting that instead of this reconstruction plate, we use a locking reconstruction plate, and yes, that would definitely increase the purchase in the bone, and that would prevent the problem. Yes, that is one suggestion. Okay, fine. So patient was taken for the surgery, and in that surgery, as you rightly said, that I was thinking of in the similar line. But then I thought that there is a problem with the purchase. And again, there is a possibility that the screws may back out in future. So let's go for a procedure which is a permanent epiphysiodesis. So half of the growth plate was drilled. So to make you understand about this procedure, this animation will give us some idea. So we are looking at the cut section of the growth plate. So we are trying to scoop or damage the lateral half of the growth plate. So we put a drill like this. Through a one hole, we try to pass a drill in different direction. Once we have achieved that, then we try to, with the help of the scoop, we try to take out the remaining part of the growth. So now if you see, we have taken the half of the growth plate, and ultimately that side will stop growing, and that will cause a permanent epiphysiodesis. So this is half epiphysiodesis. So it's a permanent hemiepiphysiodesis. So this was carried out as a solution with a fear that again there may be a backing out of the implant. And to avoid that, we decided to go for a permanent epiphysiodesis. The problem is not over at that point. 2 weeks after surgery, the second surgery, the patient says that now there is a pain on weight bearing. He doesn't like to walk, and he cannot climb stairs. His room was on the first floor, and after this surgery, the child says that he doesn't like to climb stairs. So what can be the reasons? The X-ray was taken, X-ray was perfect. So the reasons which we thought were that could be because of the mild infection. It could be some drug interaction which is with the medicine which is already taking, and that may be interfering with the existing pain relieving medicine which we are giving. Or it could be a psychological, because the child has already some cognition issue, and it could be like this. So what do you think? Any of this or anything else?
So now we have to check for this posterior cruciate ligament.
Oh, so now we have to think about the posterior cruciate ligament. Okay.
Because maybe possibly previously it is genu valgum, which we correct that, and after it he don't like to climb stairs because of the instability. So we have to check PCL, sir.
No, so
And there maybe
we have not done anything to the posterior cruciate ligament.
yes, sir.
He was behaving well till now. There was no instability at all. But you are right. We should always look back and think the investigation has suggested that maybe something giving us a help. Okay. So unexpected outcome teaches us a lot. And the most important thing, which is very important for all of us to learn, and that usually we don't learn during our residency program, and that's a communication skill. It's a very tough situation to explain to the relatives when the complication occurs. We really need to explain them in such a way that they don't lose confidence in us. So this was one of the difficult patients which I have treated in my career. We will discuss this case later. We are now going to the second case, and why we are stopping at this point, that I will tell you later. So let's go to a second case. Don't think in this case further. Okay, the case 2. It's a 33-year-old physiotherapist. She underwent IVF, and in many of the IVF which we see, they usually implant 2 fertilized ovum so that the success of IVF increases. And she also had the 2 ovum implanted. And fortunately, the pregnancy went well, and she gave birth to 1 boy and 1 girl. The family was really joyous because already she is 33. They were trying for last so many years, and IVF has given a birth of 1 boy and 1 girl, and the whole family was complete. 1 month after delivery, the mother noticed that there is a weakness in lower limbs. She has a difficulty in getting up from the floor. When there are 2 kids, she has to sit on the floor for the activities. But then she realized that otherwise she was healthy, fit. But now she observed that there is a difficulty in getting up from the floor. And because she's a physiotherapist, she always tries to look at the spine and the neurology. And she observed that she's unable to carry out SLR, the straight leg raising test. And in addition to that, there is a pain all over the body. The X-rays were taken of the pelvis and the areas where she showed about the pain. They all were normal. The differential diagnosis at this point, I would like you to think what is the problem and what we are dealing with.
PIVD maybe in some women is common after delivery.
So you are thinking of the prolapse intervertebral disc, right?
Yes, sir.
Okay, so that's the first differential diagnosis. Yes, you are right. What else?
This postpartum pituitary
Okay, postpartum pituitary. Fine. So the differential diagnosis, what the first orthopedic surgeon thought is like because there is a multiple joint involvement or multiple site pain, it could be a rheumatoid arthritis, or it could be because of the weakness of abdominal muscles. Abdominal muscles are likely to be weak during the pregnancy because they are stretched because of the two fetus in the uterus. And when they are relaxed, they become weak. And that could be the reason of our problem. Or it could be a post-pregnancy psychosis. So these are the things. Anything else? Already you thought about the PID, you thought about the pituitary problem. Anything else?
Some neuromuscular disorders, like
Some neuromuscular disorders. Okay, right. Yeah. So which further investigations now you would suggest? We suggest investigations when we are not sure. We have one powerful tool, and that is investigation. So yes, now that's the time we should go for the investigation. So which investigation you would suggest?
all routine blood investigations.
Okay, routine blood investigations, right? Then
arthritis, the profile of all arthritic diseases, arthritic
okay,
profile.
yeah, the rheumatoid profile. Okay, good. Then
EMG भी करा सकते हैं, EMG.
okay, right.
The lower
नहीं करवा सकते हैं तो we can do everything, but what you would suggest?
NCB and EMGs are also I will.
Okay, EMG and NCB. So blood investigations, that is routine blood investigations plus the test for the arthritis. Then we can go for EMG and NCB. What else?
MRI, sir.
MRI, yes. MRI of which area?
MRI spine, sir.
Spine, sir.
There
Okay,
will be
good.
epidural hepatomas.
Yeah, okay, good. So basically the investigations were carried out, and MRI of pelvis and the lumbar spine, it showed that the lumbar spine is okay, but there is a bone edema at pubic symphysis and at sacroiliac joint. Now, at 1 month of pregnancy, this could be a normal thing. It may not be normal because she underwent cesarean section. Particularly those who underwent a normal delivery, the pelvis tries to open up, and because of the hormone relaxin, there is some relaxation at sacroiliac joint and at the pubis. So there may be edema because of that. We are not sure. The all blood investigations, including the test for rheumatoid arthritis, were negative. They decided to take a second opinion. They went to some senior orthopedic surgeon in the city, and this senior orthopedic surgeon was a very experienced person. He made he examined the patient very well. First of all, he asked for the history. Then he examined the patient. He made a clinical diagnosis, and he said that I would ask only for one blood test. He's very, very different. And he said that I will go only for a one blood test. He prescribed one injection. He said that once the blood is collected, then you take this injection. And surprisingly, patients started recovering. So now I want you to think about what is that miracle drug or an injection?
GBS, yeah.
Vitamin B12.
Vitamin B12.
Serum
Okay.
D3 level, estimation of vitamin D3 level.
Okay, you are very right that the level, the blood test which was asked for was a vitamin D estimation. It came very low. It was almost zero. And the injection which he suggested was an injection of vitamin D, 6 lakhs unit. And patients started improving. So what he diagnosed clinically. So now can you tell me what is the situation? What happened or what is the diagnosis now?
Rickets के करूँगा.
Okay, fine. Let me tell you that what is the situation. So this is post-pregnancy vitamin D deficiency, which is called osteomalacia. The nature has a mechanism that even if vitamin D is low in the mother, it will shift vitamin D and calcium to the fetus. That's the nature's provision, that at the cost of mother, the vitamin D will be shifted, the vitamin D and the calcium will be shifted to a child. Because there were a twin pregnancy, the mother required large amount of calcium and vitamin D, which she was not taking or which was not suggested by gynecologist. And because of that, she developed a severe vitamin D deficiency, which results into osteomalacia. And after delivery, she started feeding. So again, the calcium via milk is going to the children. So because of that, she resulted into severe vitamin D deficiency, and that resulted into post-pregnancy osteomalacia. This is a condition which can be prevented if gynecologist would have given a proper vitamin D, because it was a twin pregnancy, and has given adequate vitamin D and calcium. This thing could have been avoided. But fine, now you will remember this, and whenever you come across any pregnant woman after pregnancy complaining of weakness, think about this situation and treat it with vitamin D and calcium, and patient would improve immediately. Coming to the case 3, this is another interesting case about a young adult who is around 40-year-old, and obesity is very common. So he went to the physician. He carried out a blood weight, the blood investigations. Lipid profile was a bit abnormal. He was overweight. The BMI, body mass index, was in the tune of 28. The normal for India is 23. And anything more than 25 for India is considered as obesity. So he was in the obese category. His blood sugar was also in a pre-diabetic range. So physician said that you really need to carry out a good exercise and need to reduce weight. So he started following his physician really well. He started walking and then running and going to the gym. Later on, he realized that he got a pain in the chest, and he went to the physician. The physician got the ECG done. It was normal. So he said that, fine, this is just a muscle pain. You continue. He continued doing all the exercise in the gym, like lifting the weight, carrying out the push-ups, carrying out the bench press. And ultimately, the pain did not subside, but it increased. So he went to the physician again. He examined the patient and found out that there was a tenderness at one rib level. So he said that let's go for the X-ray chest. And X-ray chest showed a one fracture. So naturally now the treatment is very clear. The orthopedic surgeon, the patient was referred to orthopedic surgeon, and orthopedic surgeon said that fine, rib fracture, we just need to give a rib belt and avoid doing exercise. And he improved in 3 weeks' time. He started exercise again, and this time he got the fracture, the rib fracture on the opposite side. So with the past experience, this time they were able to make diagnosis very quickly, and he improved well. But then the orthopedic surgeon said that don't go for exercise with the upper extremity, means weightlifting, push-ups, all that things you have to avoid. Just focus on lower extremity exercise. While he was going for the lower extremity exercise, he had a pain in the foot. And when the X-ray was taken, again, there was a fracture in the metatarsal. So now the question is, what is this condition? What we are dealing with?
Stress fracture, sir.
Stress fracture, right? So the first possibility is a stress fracture. You are right. So possibility is that it's a overuse fracture or a stress fracture. So stress fracture is a terminology which we use when the bones are normal and when you put an excessive load and the fracture develops. That's called the stress fracture. That is a possibility in this case. But when the patient was examined for the vitamin D level and all that, his vitamin D level was very low, almost again less than 1. That's a severe vitamin D deficiency. So again, this is a classical example of osteomalacia in adult getting a fracture. So this is pathological fracture because here bones are not normal, and because of which just routine or slightly more than routine exercise resulted into fracture. Okay, so that was again a second case. Now we are going for the fourth case. Let's see the time. Yeah, still we have 15 minutes. We will try to finish up as many cases as possible. So this is again a 14-year girl. As you can see from that, she's a Mohammedan girl and wearing the burqa all the time. When she presented to me, she said that she had a tuberculosis for which she has completed the AKT. And we can see that on the X-rays, there are lesions at 2 points, and the X-rays were in a healing stage, and so AKT was over. So she has completed AKT for 4 months back. However, when she presented to me, there was a waddling gait, means when she was walking like this, like the elderly people. So naturally, when there is a history of tuberculosis at one side, and when there is a problem at another side, we considered it's the same problem is continuing. So we thought of the tuberculosis of the hip as a pathology. We asked for the X-ray of pelvis, and this is the X-ray. So can you see anything abnormal? Fine, this X-ray looks normal. However, the radiologist was very good, and he really magnified the X-ray and identified a radiolucency at the junction of proximal and the middle 1/3 of the shaft on a medial side. To make you appreciate it well, I have put 2 arrows, and you can appreciate that there is the fracture or radiolucency. We don't know what is this. This could be a tuberculosis of the bone also. So that is what the pathology. So now the question is, what is it? And the radiologist was very clear that this is osteomalacia. So now the question is, why did she develop osteomalacia?
So this is loser's fracture, loser's zone.
Loser zone. This is loser zone. So that's typical of osteomalacia.
Yes, sir.
Yeah, you are right. So this is loser zone. So now the question is, why she developed osteomalacia?
Because of this vitamin D deficiency again.
Why? Why vitamin
Because
D?
burqa, she's having burqa, so she don't contact with sunlight.
Okay, right. So that there are 2 possibilities in this case. The one is what you said is that inadequate sun exposure because of the constantly wearing the burqa. Yes, that's the first possibility. But always remember that anti-tuberculous medicine is also likely to cause osteomalacia. The rifampicin and INH, isoniazid, both are likely to cause osteomalacia. And why they cause osteomalacia? The reason is because the vitamin D, which we are taking by orally or which is produced by the skin with the help of sun exposure, is converted into active vitamin D. And this anti-tuberculous medicine, they interfere with this conversion of inactive vitamin D to active vitamin D, and that results into osteomalacia. So in this case, there are two possibilities. The one is inadequate sun exposure, and the second is anti-tuberculous treatment. How do we manage? Naturally, when we have loser zone, we have osteomalacia and we need to give vitamin D. Just to tell you that another reason of inadequate sun exposure, this was a Mohammedan girl, she was wearing a burqa, so naturally that was one reason. But the another reason, which is very common in major cities, that people when they go out, particularly the women or the ladies when they go out, to prevent tanning by the sun exposure, they use
Sunscreen,
a
sir.
sunscreen lotion.
Yes, sir.
And we need to remember that when we apply this sunscreen lotion on the skin, this sunscreen lotion has an ability to stop ultraviolet rays coming in contact with skin. So even if there is a sun exposure, but because of the sunscreen lotion, the sun rays will not enter into the skin, and this will work as if they are wearing the burqa. So always when we take a history, we need to ask whether they are using the sunscreen lotion or not. Okay.
So,
Yeah, please.
So I think we have very less time. So if anyone have some doubt, they can also.
Yeah, they can definitely ask this thing. Otherwise, what we will do is like we will skip because here there will be no much questions. So we are continuing with that because we are going to give an important message. So let's do one thing. I will skip this question and then I will come to the first case which is remaining, because that's a very important thing which we need to understand. So this is a patient with a head injury. He had a road traffic accident, and because of that he had a bad head injury. So the neurosurgeon, they suggested that there is a injury in the brain and he's likely to get epilepsy. So they suggested that you need to go for anti-epileptic medicine. 2 years after the primary accident, the patient got pain in the right hip. Consulted orthopedic surgeon. The orthopedic surgeon would think of some possibilities. So what are the possibilities at this stage?
Again, vitamin D deficiency, sir, because patient is head injured, so maybe bedridden.
No. He was like bedridden. He was in the hospital for 10 days. And after that, he was discharged and then he's fully active. So now there is no bedridden patient.
The patient
So
is
missed injury in the hip. Missed injury in the hip.
Missed injury in the hip. Okay, good. That's a one possibility. Then else, what else?
Sir, eptoin can cause osteomalacia. Osteoporosis.
Osteoporosis, why?
Eptoin can cause, sir.
Eptoin cause, very good. So you are right on a track. So eptoin can cause osteomalacia or osteoporosis. Actually, it causes osteomalacia. So yes. So basically, orthopedic surgeon did not think about this possibility, but he thought that this could be avascular necrosis, and he suggested to go for an X-ray. And X-ray, I'm showing you the close-up view. What you see is arrow is very clearly seen. What do you see?
Yes, sir. Loser zone, sir.
Loser zone. So now you are very smart. So what is this?
This is osteomalacia, sir.
This is osteomalacia. So cause of osteomalacia in this case is anticonvulsant. Not only eptoin, there are so many other anticonvulsant medicine. They speed up the metabolism of vitamin D, and that results into a vitamin D deficiency. Right? So again, when we take a history, we need to ask whether they are on anti-epileptic medicine or not. The case 6, the child presented to me, referred to me by a pediatrician. He said that, Dhiren, this is a case of genu-valgum deformity. Otherwise, child is pale, but I don't think that there is any other issue. So I examined the child. It was apparent case of genu valgum. I asked for the X-rays. The X-ray showed like this. What do you think?
Widening of faces.
Widening of physis. Okay, so what is this?
This may be rickets.
This may be
Rickets.
rickets. Okay, fine.
Rickets.
Fine. So, frankly, I have not asked for any vitamin D test, but I have asked for the pre-operative checkup, and in that I got two important information. The first is his hemoglobin is 5.2 gram. He is severely anemic. Already, pediatrician has told me clinically that he's anemic. But the surprise was his creatinine is 7.2 milligram. That suggests
Renal rickets.
exactly. So this is chronic kidney disease, and that is basically the renal rickets. So why it happens in renal problem? We know that the inactive vitamin has to get converted into active vitamin D, and that takes place first in the liver and then in the kidney. So in a patient who has a chronic kidney disease, this conversion does not take place. And because of that, even though they may have a adequate vitamin D in the blood, it's not getting converted into active form. And that results into a clinical deficiency of vitamin D. So here, the treatment is calcitriol, which is an active vitamin D, because the problem is in the conversion. And if you give a high dose of vitamin D, even then it will not become active vitamin D. So the alternative is like we need to give a calcitriol. So now the question is how to correct genu valgum.
First, we have to correct this vitamin D levels.
Vitamin D. Then the point I would like to tell you is that when there is a renal rickets, and particularly that's due to chronic kidney disease, don't hurry up to operate this patient, because anesthesia is very risky. They have a very severely compromised immunity. So please remember that don't go for surgery in a chronic kidney disease with a serum creatinine of 7.2. So basics about osteomalacia, I will try to explain the pathophysiology. Usually the first is like the bone lay down osteoid matrix, which is shown over here. Then ultimately that gets mineralized or calcified, and this deposition of calcium in the osteoid matrix requires vitamin D. When we have a vitamin D deficiency, the deposition of calcium in the osteoid matrix is not adequate. And because of that, osteoid matrix remains soft. And in children, it leads to deformity. In adult, it leads to a stress fracture or the loser's sore. The clinical features are generalized fatigue or weakness, or bone pain, or occasionally hip pain, or waddling gait. We see the patients with different presentation. The investigation is X-rays, ultrasound, ultrasonography, or a bone scan, or blood investigations are very important because that will tell us about the vitamin D level. We may see a loser zone like this, or sometimes on the outer side, or sometimes it may be resulting to a complete fracture, or it may be showing as a sclerotic area at the upper and lower end plate. And this sign is called a Rugger-Jersey sign. So coming back to our case, we will go very quickly. And Janki, we will not have a questions on that. So let me complete this case very quickly. So this patient was on 4 anticonvulsants. Basically, we know that anticonvulsant interferes with the conversion of active vitamin D. He was offered vitamin D either as a sachet or as a tablet or as an injection. The family opted for a powder form. However, there was no response after a month. So now the question is, again, we are making a wrong diagnosis, or probably we are expecting a recovery early or something else. Now, the main point, the learning of that case is, we can give inactive vitamin D, that is vitamin D2 or D3, in a dietary deficiency, in a patient who is having inadequate sun exposure, or those who are using sunscreen lotion. However, these conditions, liver or kidney disorders, this inactive vitamin D treatment will not work. Again, medicines like AKT or anticonvulsant, which is interfering with deactivation, we need to give a treatment which is called calcitriol, that's active vitamin D. The same treatment was given to this boy. Initially, he was given inactive vitamin D, but later on, he was given active vitamin D. His pain disappeared very quickly, and in due course of time, his deformity got corrected completely. So what I want you to remember is that there are a lot of conditions which present as osteomalacia, and we need to be smart enough and something like a Sherlock Holmes and think about this possibility. Then we will be able to make our patients better. So with that, I would like to stop my presentation. I would be happy to answer your questions.
Thank you, sir. Please unmute, sir.
Thanks, Dhiren. That was excellent. I'm sorry, I have to actually leave in a minute because I'm supposed to be on another webinar. So all the best and carry on. I'll just because I'll be late on the other webinar otherwise. Okay, so
no problem. Like say, I will be happy to answer students' question.
I think you should carry on with that.
Yeah. Any question?
Yes, sir.
Sir,
Just
question, sir.
yeah.
Okay, the difference between vitamin D3 and the calcitriol. Okay, that's a very important question. So basically, all the vitamin D3 which we are giving either as a sachet, that's a powder, as a soft gelatin tablet, or as an injection, that's a inactive vitamin D. So this vitamin D gets converted in the body. In a normal person where liver and kidney are normal, they become active vitamin D. However, we also have a already converted active vitamin D3 available. That's called calcitriol. It's expensive and we should not use in a normal person. But in these patients with a kidney disease, those who are on an anticonvulsant, they should be given this calcitriol from beginning to avoid or for preventing the osteomalacia taking place. So calcitriol, ideally I should not tell you the name of the product, but the Gemcal which we are using is the calcitriol. So that's an active vitamin D.
Sir, one question, sir. In the first case, with a physial growth is not completed with valgus deformity and having on an anti-epileptic drug. Sir, so that's if we give the activated vitamin D, calcitriol. So we should try these active calcitriol, vitamin D deficiency, or directly go to the correction deformity.
Okay, so your question is like, ideally the neurophysician, when they put the patient on this anti-epileptic medicine, they should start active vitamin D at that point. So that's the primary prevention. So in this patient, we failed primary prevention, and ultimately that resulted into genu valgum deformity. It's a mistake on my part that before I took the patient for surgery, I missed that point, that anticonvulsant. I was not knowing at that point that anticonvulsant can cause this problem. I came to know about this problem after two complications. The first, the backing out of implant. Even at that point, I did not thought about that something is going wrong. So I missed that opportunity of making a right diagnosis at appropriate time. And that's why I presented this case that this can happen with anyone. And those patients who are on anti-epileptic, please start calcitriol from beginning and don't jump for orthopedic surgery.
Yes, I think Amil has one question. Amil,
Yeah.
just ask.
Sir,
Yeah, please.
dose and duration of calcitriol, sir?
Okay, the dose and duration of calcitriol, it comes as a 0.25 microgram tablet, and we can give once a day. That's the full dose of 0.25 microgram once a day.
Durations?
Duration, like say, till they are on anti-epileptic, we need to give them.
As a renal rickets?
In renal rickets, so either you treat the renal problem by the liver transplant. Till then, we have to give this medicine. Once they undergo renal transplant, we don't need to give them this. But before that, we need to give calcitriol to all the patients with chronic kidney disease.
Thank you.
Yes. I think we have taken all the questions. Pushpender, do you have any doubt? These are exam going batch.
No, thank you, sir.
Okay.
So thank you everyone for active participation, and I'm sure that this case will be in your memory because you have thought about this case, and definitely this will be a good learning for you.
Thank you,
Thank
sir.
you very
Yes,
much,
sir.
sir.
Thank you very much.
Great, sir.
Thank you, sir.
Yeah. Bye.
Thank you, sir.
Thank you so much, sir.